Hi, good afternoon, everyone. On behalf of GBS, I want to say thank you and welcome. We're going to go ahead and get started. To be kind of aware of everyone's time, we appreciate you joining this afternoon. This is our first webinar in our ongoing series, and we're going to go ahead and get started. The series we're looking at here is our healthcare education series, Navigating Healthcare Trends and Technology. We're going to have about 7 or so of these over the next few months on various topics that we've heard from you and others that have been of particular interest. We're really glad that you could join us this afternoon. Today's timely discussion is going to be regarding pre-election regulatory updates and what this means to your business. I'm Lindsay Bruderly. I'm the Sales Operations Manager with GBS, and I'm kind of going to just do the intro and the conclusion here. Before we go ahead and get started, I wanted to let everyone know, as attendees, you're in listen-only mode. So if you have any questions, you can go ahead and utilize the chat feature functionality during the presentation, and if time permits, we're going to open the phone lines up at the end for questions and answers. So feel free to ask questions at any point in time during the presentation using the chat feature. I'll try and answer any of those questions as they come up. All right, so some of the things that we're going to be talking about in our education series, we're going to provide some insight and education. Today's is regarding our regulatory and our compliance mandates. We're also going to feature some topics regarding patient engagement, financial health, technology flexibility, scalability, security and infrastructure, as well as patient and staff safety. So with that being said, again, I just want to thank you and welcome you all. I'm going to hand it over to Chris Emper. He's the president of Emper Healthcare Advisors. He provides healthcare industry and government affairs advisory and consulting services. Some of you may be familiar with him. He specializes in helping healthcare providers and technology companies successfully navigate health IT regulations. And he also serves as a government affairs advisor to several industry-leading healthcare technology companies. So with that being said, I'll pass it over to Chris.
Great, thank you, Lindsay. Thank you to both Lindsay and the rest of the team at GBS for having me here today, and thank all of you for joining. We have about 45 minutes or so of a presentation here that I'll walk you through. As per the title of the presentation here, providing a pre-election regulatory update, things that are going on in the healthcare industry, and specifically things that have been happening, over the last 6 to 9 months, with an eye towards so much that has changed recently, and it's been tough to keep up with all of this, especially in the context of COVID. And I think as my next slide here shows, as everyone has, really lived through the past 6-9 months, or really since March when the pandemic started, there's never been more regulations that we've had to deal with, all of us working in healthcare. And for those, unlike me, whose day job it is to sort of sort through and read all these regulations, it's been tough to keep up with. And not only because you've had, shutdown orders, waivers, different aid programs to educate yourself about, figure out if you want to take advantage of them or not, different public health guidelines and things you need to do just around, how to manage your practice and reopen your practice, and then the reopening orders. And that's all just related to COVID. And there have been multiple sources of these rules and regulations. You've had the federal government, state governments, county governments, even townships. You have local mayors and city councils with their own rules. If you're participating and have privileges in a hospital, you have to deal with the hospital's rules. Similarly for a surgery center, and then within a physician practice, if you have multiple locations across different states, counties, localities, and even within different specialties, different rules and the different specialty societies, weighing in. So it's been kind of a mess the last 6-9 months to keep up with this, all while, trying to deliver care to patients who need it during the pandemic, with regarding to things that have to do directly with the pandemic, as well as all the other care non-pandemic related, that has continued and needs to continue to go on. And I think some of the things to keep in mind as I walk through this presentation today are considering all these changes that have happened, what is going to stay in place after the pandemic, which are temporary measures, which are permanent measures, and how potentially might the election in the next few months, as some of these things, temporary programs have end dates or might wind down, what's going to happen regarding them. So the agenda that I'll walk through, first touching on, from a congressional standpoint, what Congress is currently up to, a review of where they've been this year and the major changes they've made as it relates to COVID and other healthcare related items. Then I'll touch on the election and talk about, where we stand today, just a couple weeks out from the election day, and then ultimately highlighting, what that will look like from an implication perspective for healthcare practices. As a second part of this series, this is the pre-election update. We're going to do a post-election update already scheduled by the GBS team for December 9th, which will go into more detail around exactly what the implications will be of the election result. So as much as I'll highlight what's going to happen in the election and sort of preview what we might be dealing with right now, the primary focus of this presentation today is going to be on everything that's happened up until this point. So both legislatively, and then after talking about the election, also diving into the recent regulatory updates and ultimately what healthcare providers need to be aware of in that realm. And then again, I'll leave a few minutes for questions at the end. I think also feel free to type them into the chat box on a particular issue, and we can see if we can address them as I go on. So diving into the election updates, just a placeholder here, COVID aid, the election, and the outlook. So this has been the federal government's response to the emergency. They've had different phases of major COVID aid or COVID stimulus packages, as they've called them. Going back into early March, they passed 3 laws in March. The first one on March 6th, the second on the 18th, and the third on the 27th. The first one was $8.3 billion total. The second, $100 billion, and then the third, which is the CARES Act, $2.2 trillion. This was the biggest of the laws, and something that went into effect right around the time that all the shutdowns were happening. And as you see, the pandemic and the seriousness of it started to take hold in March. You see the size, the price tag of these bills increase. The phase 3.5 bill that they call, which is the 4th bill passed, they called it phase 3.5 because it just really added additional funding to some of the more popular programs from the phase 3 law, the CARES Act. So it was $484 billion, about $500 billion added into some of the key programs from the CARES Act. So those are the 4 laws that passed this year, even though they're called phase 3.5. For the 4th one, in every circumstance, as I've been doing this for quite a few years, there's the sort of acronyms they'll use or the different language they use within DC to describe things. It inevitably never makes total sense. And this is another example here. We have 5 laws, but we're looking at, phase 3, phase 3.5, and 4. So a little confusing to keep track of. But nonetheless, the 5th bill, what would be the 5th bill, is phase 4, and that's currently under negotiation, although has not been passed and seems unlikely to pass before the election at this point. But my next slide shows a little bit more detail on the phase 3 law, the CARES Act, the Coronavirus Aid, Relief, and Economic Security Act. This is the biggest program. Again, over $2 trillion of benefits or of programs and aid and stimulus and regulatory waivers passed back in March at the time to address the next several months of shutdowns and COVID concerns that were there at the time. This law touched on everything from individual and family aid programs, extended unemployment insurance benefits, the direct cash stimulus payments to individuals, as well as business provisions, and then healthcare industry specific provisions. So in terms of generally applicable business provisions, you had different tax credits or delays or relief programs. Specifically for small businesses, the Paycheck Protection Program or PPP program was eligible for, created a program for small businesses defined as those with less than 500 employees, which included many healthcare physician practices and other businesses in the healthcare sector, were eligible for assistance in the form of essentially a grant that did not have to be paid back over time. It was a very popular program. Was allotted $349 billion in the CARES Act, and then an additional $310 billion in that Phase 3.5 law, to total $659 billion. So, over $500 billion in this program. There's still some funding left in it, but it was obviously a very popular program, and extending the time constraints in the program is something under consideration for a future bill right now. Another key program for healthcare providers, specifically for healthcare providers, hence the name, is the HHS Provider Relief Fund. So in the CARES Act, they put $100 billion and gave it to HHS to dish out to hospitals, physician practices, and all healthcare providers to essentially make up for lost revenue as a result of having to shut down due to COVID, and then the increased expenses incurred as a result of some of the PPE and other infrastructure investments that needed to take place to care for COVID patients. This program, again, was very popular, and another $75 billion was put into the program for in the Phase 3.5 law, to total $175 billion. Unlike other programs, this money did not have to be paid back. And there were a couple different allotments and announcements from HHS around how they gave this money out. There's still money in the fund and sort of more to come there. But the first funding through this program came in the form of a couple weeks of, what amounts to a couple weeks of Medicare reimbursement for every provider or hospital in the Medicare program. And again, significant that there were some minor restrictions around use of the funds and what you have to do, but essentially as a grant, it did not have to be paid back. The next program, the Accelerated Loan Program, was a program to provide a lump sum payment in the form of 3 months of Medicare reimbursements to sort of improve cash flow. It was scheduled to be paid back 6 months after the start of the program. A recent announcement from HHS, major announcement, was that they're going to delay repayment of that program, the start of that repayment program, until a year after the disbursement. So that money will have to be paid back. I will also mention that in the Phase 4 law that's under discussion now, and any other future legislation, they're talking about forgiving some portion of that funding, especially because if you consider them adding additional programs to help support providers and lost revenue, forgiving that these funds would be sort of a shortcut towards doing that, and kind of some administrative simplicity added to the process, but to be determined on that. And then the final two bullets, as they show here, additional targeted funding across different types of federal programs, lifting the Medicare payment sequester, the 2% cut that's been in place for years, through the end of 2020, and increasing hospital inpatient payment rates for COVID-19 positive patients by 20%. Meanwhile, an extension of federal grant funding for community health centers through November, and then supplemental grants in the form of $1.32 billion across the 1,000+ community health centers, which averaged out to just about $1 million per center. And there was additional funding through other legislation as well to help kind of tide the wave of the COVID pandemic back in the spring. So major programs, again, a $2.2 trillion law. And if you're running a medical practice, not only do you have the generally applicable programs for individuals and for businesses, but these healthcare specific programs as well. Where the negotiations stand right now on the fourth package, the fifth bill, it's likely dead until post-elections. For those who have been following the national news over the course of the last week, there's been discussion of this because last week the president tweeted out that the negotiations were off and they were dead until after the election. Then this week they've kind of come back and they're positioning around what they might do. The short summary is that Phase 3.5, the last law, was signed on April 24th, and they've really been negotiating since then. Obviously, $2.2 trillion was a large bill, the CARES Act, and it was meant to survive, to last many months. Back in May, the Democratic-led House passed a $3.3 trillion bill, and it said that the HEROES Act, it was called the HEROES Act, and it basically set the marker for where the Democratic-led House would be over the course of this summer in these negotiations. The Republican-led Senate never took that bill up and has always considered a smaller approach. And the negotiations have been led by Speaker Pelosi on the Democratic side and the Treasury Secretary, Steve Mnuchin, on the Republican and obviously the White House side of things. They've been negotiating for months and have never really gotten that close. As it stands now, I think the highest bid that the Secretary Mnuchin has been willing to go has been $1.6 trillion, and Speaker Pelosi is at $2.2 trillion. There's a lot of political and obviously right before the election policy considerations last week. Unclear if they'll bridge that gap. They're pretty close, 1.6 and 2.2, but there's some major political differences in the bill beyond the price tag. So we'll see what happens. This will remain a news issue, and it's important for healthcare practices and physicians because any bill that's likely to be passed is going to have many of the same programs that were in the CARES Act, as well as amended and different aid programs. So, stay tuned on that. I think it's very unlikely that we'll see something pass in the next few weeks before the election, but I think it's extremely likely that we will see something pass post-election.
And Chris,
speaking of the election, as my next...
Sorry, Chris,
sure,
to interrupt you before we move on to speaking about the election. We did have a question come across regarding the PPP loan forgiveness application. It looks like Ruth said, I've heard conflicting information as to when we should complete the application. Do you have any info on when the forgiveness application should be completed?
Great question. I do not have any specific guidance on when the application should be completed, and I would defer your question directly to your bank and your financial institution as to when that should be. I think as quickly as possible. I know you had to go through the period of the first several months of the loan to ensure that the qualifications of the loan were met, including the keeping people employed, which was one of the big provisions around the forgiveness of the loan. But ultimately, I would guide that question towards your financial institution.
Okay.
And I'll just add, with all of these programs, the devil is always in the details. And as helpful as some of these programs have been, there's obviously been a lot to keep track of. And they've been the guidance from CMS, HHS, as well as for the PPP, the SBA, the Small Business Administration, has been constantly changing. So I think, keeping up on that has been a challenge in and of itself. So our election slide here. So again, in my December 9th webinar, I'll talk more in depth about what happened in the election. Hopefully we'll have a result by then, and ultimately what the implications will be. If you can just pull back to this one for just a second here. But obviously we have the election set between President Trump and the Democratic nominee, former Vice President Biden. Right now, the polls show Vice President Biden ahead, nationally more so than in some of the key swing states that will ultimately determine the Electoral College. That being said, we still have time before November 3rd. A lot can happen, and we'll obviously just have to wait and see what the result might be. From a healthcare policy perspective and a COVID perspective, there are some key differences between the candidates and what that might mean in terms of regulations and legislation that comes out. But I think one important thing to remember, and I've highlighted this at the bottom, is in addition to the president, the split between Congress. And right now, as it stands, I have highlighted at the bottom the current 116th Congress, with the Democrats in control of the House and then the Republicans in control of the Senate with a 53 to 47 majority. Ultimately, it will be difficult for whoever wins the presidency to pass any major healthcare reform legislation without having single party control of both the House and the Senate. And if you think back over the last decade, you had the first 2 years of President Obama's presidency, 09 and 010, and the first 2 years of President Trump's presidency, 17 and 18, were the only 2-year periods where that president had both the House and the Senate. After the first midterms, it flipped back to the control of the other party, and we've had less major legislation produced. So if you do have a scenario, and right now it seems very unlikely that the House would be flipping back to the Republicans, so in all likelihood, the only scenario where we have an aligned single party control of each of these three aspects of government would be if you had a President Biden, Democrats in control of the House, and the Democrats flipping the Senate to have their control. That's the scenario where we likely see major, single party healthcare reform legislation. So the key thing to keep an eye on here from a perspective of our healthcare industry, I think, is what happens to the Senate and keeping close control and an eye on those Senate races as they come in on November 3rd, which will be just as important, if not more important, than who wins the presidency in terms of the future of healthcare legislation over the next 2 years. So with that being said, and kind of leaving it there for now on the election, key dates to keep in mind here over the next 2 months, 3 months really. Election day, November 3rd. There are key funding deadlines that will force essentially some action by Congress over the next, before the end of the year. November 30th, there's a deadline for what they call healthcare extenders, a series of different programs that used to be tied up in the doc fix, the SGR, if you remember back to those days. But they're programs that they temporarily extend every year or 2 years. Community Health Center federal grant funding is one of those programs, but these are considered must-pass items that both political parties will pass, and they'll have to do something on that by December 1st, ultimately. And then you have on December 11th, government funding. They recently, on October 1st, ahead of October 1st, I should say, in the wee hours of September 30th, passed a bill to temporarily extend the overall government spending and avoid a government shutdown until December 11th. So on December 11th, they'll have to pass another spending bill to avoid a government shutdown. So you have those two deadlines, November 30th and December 11th, forcing some level of bipartisan movement in Congress. And because they are considered, quote, must-pass pieces of legislation, there's an opportunity there to attach other, COVID relief or healthcare policy changes. So I do expect it to be an active lame duck session here. After the election, it's not going to be, regardless of what happens in the election, they'll have to pass some legislation, in November and December. So stay tuned for that. And then, looking into early next year, there also is a period of time, if we do have a change in the presidency, where the new Congress is actually sworn in January 3rd, right at the start of the year, and the inauguration day does not take place until January 20th. So there is a couple-week gap there where if you have some changes in the Senate or the House and a change in the presidency, that won't happen yet. So a lot happening in the next month, and obviously if we do have a change in the presidency, you'll have a presidential transition, new policies to look ahead that they'll be teasing out, and appointments across all the different key healthcare areas, CMS, HHS, ONC, et cetera. So it's going to be quite a busy couple months, starting with and kind of kicking off on November 3rd, I think, really in the healthcare world, regardless of what the result of the election will be. And again, December 9th, please do tune back in, and we'll talk about the results of the election and what the ultimate outcome of this legislation is going to be. So leaving that as our legislative and congressional and election updates, I want to turn to some regulatory updates. Talk about COVID. I'll talk about the CMS payment rules and other changes that we've seen over the last 6-9 months. And as I mentioned up at the top of the hour, it has been the busiest year I can remember with all the different regulatory updates. Both because we had a lot of action even before the pandemic, with it being, an election year and a lot of ongoing work that had been built up over the last few years, but also then all the COVID rules that have happened. And as my next slide shows, if you can remember back to before COVID, this was the political and policy agenda, healthcare policy agenda of the administration. HHS Secretary Alex Azar came in 2018. This is post the attempts of President Trump and the Republican-led Congress to repeal and replace the Affordable Care Act. And he came in with this new agenda, as you see here in 4 bullets, around the opioid crisis, the price of prescription drugs, the cost and availability of insurance in the individual markets, and then value-based transformation. And, you know, if you're a healthcare provider and you're thinking about this agenda and ultimately what it meant, the first 2 were largely focused on the pharmaceutical and the drug industry. The third largely focused on the insurance industry. And the fourth kind of squarely pointed at the provider community and the government using their power, you know, through the Medicare and Medicaid programs, but also different regulations to move towards what they've called the value-based transformation of America's healthcare system. And as my next slide shows, Secretary Azar and the administration went one step farther beyond that plan, and they actually laid out a 4-point plan for how they're going to move towards value-based transformation. The 4 different planks of that plan were moving forward with data interoperability across different systems and providers. And this was seen and made a reality through the interoperability and information blocking rules that they released and proposed in final form over the last few years. Their price transparency initiatives, a couple different regulations there touching on both hospitals and then insurers, primarily with the first wave, but looking to expand further in the future. Value-based payments and using through the Medicare and Medicaid programs, value-based payments, making them mandatory where possible, and then fully implementing reformed versions of their Pathways to Success ACO program and the primary care programs that were all set to be in place before the pandemic in 2021, but have since been slightly delayed or changed the requirements around. And then the fourth, you know, where possible, as tied really to the fee-for-service world, you know, outside of moving the payments to value and everything to do with the value-based world, trying to simplify burdens wherever they can in the fee-for-service system. So the E&M, or Evaluation and Management Coding System overhaul, which I'll talk a little bit about, their attempted move towards the MIPS Value Pathways, or MVPs, a streamlined version of MIPS, and other initiatives that they've rolled out over the last few years. So this is what the agenda was, and it was kind of coming to a culmination before the pandemic throughout this year. You know, you had mandatory new value-based payment models, you had the interoperability, information blocking rules, the price transparency rules, the E&M coding overhaul, the MIPS value pathways, all set really for implementation either this year or January 1 of 2021. And then the pandemic hit. And it's tough to keep track of what has changed, what has been delayed, what hasn't since the pandemic hit. Here's just a snapshot of one of those initiatives to give you a sense. So this was actually right at the very start of COVID, March 9th, if you can remember back then. It seems like a different world from now. Originally scheduled for release the first day of the HIMSS annual conference in Orlando, March 9th, with a speech in person from the president himself, were the interoperability rules. So this was canceled just the week before, and I remember at the time it being quite controversial because they hadn't announced the lockdowns yet. They were just starting to cancel events. I think this is before, even for those who are sports fans and remember, that later that week is when they canceled the NCAA tournament and the conference tournaments for college basketball. So it was really at the time where we didn't know exactly what this was going to be, and this response to cancel and postpone so many events. But they canceled the conference but released the rule, and then over the course of several months, the rule was released on March 9th. It was officially published in the Federal Register on May 1st, but they announced enforcement discretion and ultimately we're going to delay compliance due to COVID for 6 months. And then they have since, as my next slide shows, they're even now discussing a further delay to the program, the requirements. This is just from a couple weeks ago. COVID continues to impact the regulatory agenda set in place before the pandemic, because after they had announced this enforcement discretion and said they were going to delay things a little bit more. Here you have the head of ONC, Dr. Rucker, saying just a few weeks ago at a conference, they might have to push the rules back again. And ultimately, as you see in quotes at the bottom, they have submitted a regulation to the White House Legal Counsel Office of Management and Budget that'll soon be released. That, as the title here says, although we don't know exactly what's into it, in that regulation, excuse me, some delay in the compliance dates and time frames in response to the public health emergency and COVID. So this has been the situation throughout this year and has been reflected through the different regulations, where we're dealing with the two different worlds, where everything I just showed you that they were trying to do before COVID and their broader healthcare policy agenda is still happening, but it's probably delayed or impacted in some way. And we've seen that reflected through different regulations this year. Meanwhile, we've had all the different COVID-related changes that have happened over the last few months. As an example of them, my next couple slides show these different rounds of regulatory changes. And just looking back into March again, which seems quite a long time ago, CMS released two major rounds of regulatory changes for the emergency. The first one you see on the left, the press release from CMS here on March 30th. It was a 200-page regulation and made a variety of different changes that went into effect immediately. Some that were authorized by those three March laws that we've been dealing with and have been largely tied to the emergency declaration this year. Telehealth changes were one major aspect of this regulation. The next slide shows the second round of these changes, which was a month later in late April, and similarly a 200-plus page regulation that implemented certain aspects of those March laws and included, in response to the pandemic and what providers were saying, another round of changes around topics such as Medicare telehealth, ACOs, and other regulatory requirements in the pandemic. So a lot to keep track of this year. My next slide shows even further, keeping track of the public health emergency declaration. So this is something that HHS originally did back in the winter, and a lot of the policies that are in effect right now for the emergency and that were in those regulations I just showed you are tied to this emergency declaration. The declaration can only be extended for 90 days at a time. It was last extended on July 23rd, set to expire October 21st, so just a week from today. Going to be extended again. I have not actually checked this week. I don't think they've done it yet, but everything with all the telehealth and other policies tied to this, they are going to continue extending this for the time being. But again, just want everyone to be aware from a regulatory and compliance perspective that so much is geared towards this emergency. And once this emergency declaration ends, whenever that is, a lot of the policies that have been in effect this year will go away absent a change from Congress or other regulation. As an example of this, I'll flip to the next slide, please. Telehealth changes. And I'll talk more about this in a few slides as it relates to what has changed during the pandemic and what the new Medicare regulations for 2021 propose to make permanent. But there were, a series, half a dozen changes announced throughout March and April, and even throughout the summer. This is just an example from there about the changes that were, geared towards the emergency. And again, once the emergency ends, in each different area that has been so impacted by COVID and by these regulatory changes, it's important to keep in mind what will and won't change. Next slide, please. So this all brings us up to the Medicare 2021 proposed physician fee schedule rule, which I'm going to spend about the next 10 to 15 minutes and the rest of my presentation walking you through, because this is the key regulation every year that CMS releases for policies that will take effect January 1 of the following year. So this year's rule will take effect January 1, 2021. Important this year because it wraps up a lot of the includes a lot of the temporary COVID policies and kind of hints at what the future of those might be. four key areas of reform in this rule, though, that I'll talk about. Telehealth services changes, which I just mentioned, the E&M office visit coding and payment system reform, which is going to be a big change, MIPS changes, and then ACO quality measure changes. And for this rule, do note that overall, it's a proposed rule. It was over 1,000 pages. It is now going into the final rule phase. The final rule will be out sometime likely in November, ahead of the January 1 implementation. So because of COVID this year, it's going to be a little later than usual, but it is significant that it was just in the proposed phase, and what I'll walk you through right now is subject to change in the final rule. And again, hopefully on that December 9th webinar, I'll have a little bit more information on what has been finalized, because it's supposed to be out by December 1st. Ultimately, again, for January 1 implementation. Around telehealth services, though, furthermore, just to mention that if you had followed coming out of the White House, and the President held a press conference in conjunction on the same day you see here as the release of this rule around making permanent, and as it says here, Trump administration proposes to expand telehealth benefits permanently beyond the emergency. So it's tough to keep track when you see that press release and the rule, and you wonder exactly what has happened. As the next few slides show you, I'm going to break down exactly what has and has not changed. So for the Medicare telehealth services program prior to COVID, the COVID emergency, the rules were very restrictive. And basically, you had to have a patient who was in a rural geographic area, as defined by HHS, physically located at a healthcare facility. So the patient couldn't be at their home. They had to go into what's called an originating site, which would be a hospital or a physician's office. The provider providing the telehealth service had to be one of those approved by HHS on their list, which they call distance site practitioners. The technology had to be real-time audio and video, so it couldn't just be a phone call. It has to be interactive live audio-video system. And then the service had to be among those codes covered by Medicare. So it was a very restrictive program, with the first two, the geographic, only being in rural areas and only being for patients who go into a healthcare facility, off the bat being pretty restrictive. So for years, physician advocates and those in the industry, telehealth companies, et cetera, had lobbied CMS and Congress to change these rules and said that, telehealth is real, it can improve access to care, but these regulations don't allow, it to be taken advantage of in the Medicare program. So during the emergency, as my next slide shows, they made all of these changes. So pretty much all these changes, I should say. In each of these areas, you see a line drawn through what, was the rule outside of the emergency, and then highlighted and underlined what is the policy during the emergency. So through that series of a dozen regulations, this slide shows where we're at right now during the emergency. So the patients geographically can be located anywhere. They can also be anywhere physically, including at their homes. The providers, which the typical list includes physicians, NPs, PAs, they've added community health centers, as well as physical therapists, occupational therapists, and speech-language pathologists to the list. The technology still has to be real-time audio and video, but they've added a separate category for real-time audio-only calls, so phone calls, to expand access. And then they've added 80+ services to the list of what's covered under Medicare's telehealth services program. They also changed the patient copayment requirements and the billing requirements and the codes that you use to allow these telehealth visits to be paid the same as in-person visits, which is not the case outside of the emergency. So this is what's in effect during the emergency, and for the last few months, physician groups, telehealth advocates, and companies have been lobbying Congress to make all of these changes permanent. My next slide shows what was made permanent or proposed to be made permanent in the rule. And really the only thing it addressed is that fifth bullet in my last slide, adding certain telehealth services or codes, CPT codes, that are payable under Medicare, to authorize them for payment starting next year, some of them, by the Medicare program. And this shows there are two different categories. It's kind of technical, category 1 versus category 3 additions. But basically, out of the 80 services CMS is proposing or has added during the emergency, they're proposing to add 22 of them, only 22 of them, to the permanent list. And as my next slide shows, overall, when you look at what this rule would do, if the emergency ended and you had in effect this new rule, the only thing that would change would be you'd have an additional 22 services payable. So all of the things that have restricted the program, including the geographic restrictions, the patient being at home, having to be real-time audio and video, they would revert back to the old rules absent an act of Congress. So again, the key takeaway here is that, despite a lot of coverage in the industry, any change would only change that fifth bullet, and you'd still have to deal with the geographic, the location, the provider, and the technology rules under the old system. We'll mention that Congress is working right now on bipartisan legislation to make some changes here. Some of that could happen in the lame duck session or as part of these continued COVID relief bills, because telehealth is a very bipartisan issue that everyone wants to see continue, but ultimately we'll have to see what happens. Next slide, please. Also just want everyone to be aware, depending on where you are, obviously, as I'm sure you all know and have been following, a lot of state and individual insurer, commercial insurer policy changes for telehealth in the emergency. Some of those are starting to change back, revert back. Others are being made permanent. The left here shows a CMS federal waiver, everything filled in blue, which means an approved waiver under the Medicaid program for Medicaid providers. And then again, commercial insurers, sometimes on their own, sometimes in response to a state law, have made similar changes during the emergency as well. Next topic I'm going to talk about is the E&M coding changes. So this was all finalized in the 2020 final rule. Has been several years in the making, and really decades in the making, if you consider that this goes back to the 1995 and 97 E&M guidelines for selecting the different code levels. So you have your 5 levels of codes for new and established patients that have been in place for years. They are going to do all of these things you see on the left, these 10 changes that were finalized in the 2020 final rule. They're moving forward in 2021. So you see the quote on the right there, CMS confirming in this rule that came out this summer that they're moving forward with these changes, largely received positively by the physician community, although there are some changes to the payment levels. But really the big changes to be aware that are happening January 1, 2021, you're going to retain 5 levels of coding for established patients, but reduce the number of levels to 4 for new patients by deleting the level 1 code 99201. Revising all code definitions, only requiring history and exam for code selection as medically appropriate, and ultimately allowing clinicians to decide to choose the level of visit based on either medical decision-making, MDM, or time. Then they've also changed the payment values and made some add-on codes that are going to impact reimbursement as well. In regarding time, my next slide shows a little bit more detail on this, and I'll won't go into the details here, but these are all quotes from the AMA CPT editorial board, which creates these regulations that have been adopted by CMS around these different new rules. But ultimately, time is not just time spent with the patient, it's face-to-face and non-face-to-face time spent by the billing practitioner, by the practitioner only, not by the staff, on the day of the visit. And as they say here, they list all the different non-clinical or non-direct patient time activities on the right that you see that could be included here. So one of those, as I've highlighted here, is documenting clinical information in the EHR. Others are ordering tests or following up with patients. So this is quite a big change. And for the first time here, CMS, as laid out in the slide, if you choose to go and document your visits based on time, you get you count not only the time that you're in the room with the patient, but also the time that practitioner spends doing any of these tasks outside of that. And in terms of reimbursement changes, the next slide shows what those will be. So again, we've eliminated the level 1 patient visit for new patient visits. Meanwhile, I've added the times in there, the estimated times that it would be if you're using the time option. And then I have the 2020 national payment rate for Medicare and the proposed payment rate for 2021. Clicking to my next slide shows what these increases would be or decreases. Basically, it's a slight decline for a few of the new patient office visits, but a double-digit increase around the established patient office visits, which for many providers who spend most of their day billing these codes and seeing patients back to back in the office, they're going to see an increase in reimbursement in addition to the changes in how you document these visits, as you see proposed here. In addition to these new payment rates, one other thing they've added are add-on codes. So a new $16 add-on code, GPC1X, that was proposed in the regulations last year and added as final this year, although they might tweak some in the final regs. They could be added for every visit, and I have some more details on the next slide. But also added is a prolonged services code. So for any level 5 visit, if you're using time and you do a level 5 visit and you go beyond the allotted time for a level 5 visit, you can have an additional reimbursement for every 15 minutes you bill above that. And some details from the rule here, and I've provided the page numbers just as a way of saying that these policies are going to move forward. There are some questions from the provider community, and they'll be sorted out by CMS in the final regulations. But again, a pretty significant change when you consider all of these reforms added up together. And as is reflected on my next slide here, the implications are going to be significant, and they're going to vary across different physician specialties. So overall, because the Medicare spending under the fee schedule has to be somewhat budget neutral each year, because they've increased spending for these codes and these codes are so widely used, it triggered an automatic cut elsewhere in the fee schedule. And this is very technical, based on how they set up the fee schedule years ago. One of these things where if they increase spending in one area, they have to cut it in other areas based on this technical formula that you see here. What it amounts to is essentially about a 10% payment cut, 10-11% payment cut for every code in the physician fee schedule next year. And this cut is already baked into the percentage increases I showed you on the last slide. But for different specialties, this really means if you see a lot of patients under these E&M visits and bill a lot of 4 and 5s and see, complex patients with longer visits, you're going to see an increase. Family practice projected as a 13% increase, general practice 8%, oncology 14%. Meanwhile, the surgical specialties and those who are not, billing E&Ms at a high level or billing more level 2s or 3s are going to see more decreases. Anesthesiology, general surgery, radiology, as you see there. Obviously, this has been quite controversial, and I included a couple quotes at the bottom left there to show what the industry has been saying. There's been a lot of pushback from physician lobbying organizations and specialty societies, especially those specialties who did not do well or are not projected to do well under this program. And there's lobbying Congress and CMS to try to waive these budget neutrality laws and ultimately to get rid of that 10% payment cut. And I think there's a decent chance that that may happen in the end, remains to be seen. But obviously during the pandemic and with physician practice revenue being so greatly impacted, not a politically popular physician to be cutting pay as a result of these changes. So we'll see what happens. Again, the final rule will have more to say in a few weeks when that is released. The next issue I wanted to talk about is MIPS changes. I won't say much about this because there really weren't any major changes from 2020 to 2021. You see here on the top, I've highlighted the scoring system and the evolution of the percentages that each of the 4 categories in MIPS count for. This year we have 45% quality, 15% cost. Next year it's going to be 40% quality, 20% cost. Promoting interoperability and improvement activities stay the same year to year. And then the overall performance benchmark, it's going to go up slightly. This year it's at 45. Next year it's going to be at 50. This is the number out of 100, based on a score of 100, that you need to get above to get a positive incentive payment adjustment. and then if you're below it, you'll be subject to a penalty. Also notable that we've maxed out the penalties, the potential penalties, and you're at 9%. The bigger change is that the MVPs program, MIPS Value Pathways, which was a major rebranding and reform of the program, a broader reform that they announced last year and was scheduled for January 1 of 2021. They are not moving forward with that due to the pandemic. And I've included the quote here, and they've kind of said, we still like the idea, we might be looking at it for 2022, but unlike as we said last year, we're not going to be introducing any MVPs into the program for 2021. So that is a change. Also, they added more flexibilities and announced more flexibilities in this rule. Specifically here, I've documented what they've done for alternative payment model participants because that was not something that they did through the previous regulations earlier this year. The last thing I want to touch on are the ACO changes included in this rule. For those participating in ACOs, you have to submit your quality measures every year. Earlier this year, through the emergency regulations released this spring, they made a series of changes to the ACO program to essentially exempt any ACO participating in the program this year from having any losses as a result of COVID, because obviously COVID kind of throws off the projections and everything that might be associated in the program. For next year, they're proposing, kind of separate than COVID really, a wholesale reform of the ACO quality measures that they're required to report. So currently you're required to report 23 measures. Next year, they're saying you only have to report 6. You see the little star I have in that first bullet though, that points down to the box at the bottom right. One thing to keep in mind is that under the current program where they have 23 measures, the CAHPS per ACO survey, that's the consumer survey, is counted as 10 separate measures. They're still going to require that next year, but it's only going to count as 1. So I think this is a little bit disingenuous of CMS to say that they're reducing the number of measures of 23 to 6. It's more like 23 to 16, but still a change there. And from a scoring perspective, will be a big change. But for those in the ACO program, wanted to make sure you're all aware of that, especially as it includes some COVID-related changes. So through these 4 different areas, telehealth changes, E&M changes, MIPS, and ACOs, we're looking at a big part of both the fee-for-service and the value-based payment system, and some big changes included in the rule. Again, this is all proposed, likely to be finalized over the next few weeks through the final regulation. With that, that brings me to my final slide, I believe. What to watch for next? So obviously a lot has happened the last few months. A lot will happen in the next few weeks. The election is set for November 3rd. Healthcare issues are going to be center stage, and ultimately will have an impact on what not only Congress does the rest of this year, but early next year as well. The key question being, will that phase 4 COVID relief law happen either before, which I think is unlikely, or ultimately after the election? Remember the November 30th and December 11th must-pass deadlines for Congress. They have to do something. No one wants a government shutdown, either political party, so that will ultimately lead them to have to pass a law that possibly you'll get, telehealth or other healthcare or COVID aid bipartisan work attached to. The final rules I just mentioned coming out later this year. And then, just looking a little further down the line into early next year, from both a state government and a federal government level, depending on the election and the broader economy, are there going to be some bigger and more wholesale changes to healthcare policy? I think there's a potential for that, and especially as the pandemic continues on, there becomes a more significant potential for that to happen depending on the results of the election. So stay tuned for all of that. I know it's a lot of information to absorb, but I certainly appreciate everyone joining us today and your attention. Happy to take questions. I think I ran a little bit long. I'm not sure if we have any time for before we wrap up here. But again, I'll be back on December 9th to do the post-election outlook as well.
And we do have a couple minutes left for questions. I do want to kind of do a wrap up too. So I'm going to unmute everyone. So just be aware that if you got dogs barking in the background or, you know, coworkers talking, if you just want to mute yourselves if you're not going to ask a question. So there we go. We should, all right. I tried to do does anyone have any questions? Looks like a lot of people have yourselves on mute there. Okay, well, I will conclude here with thanking all of the attendees for their participation in today's educational session. Hope that you were able to find some good bits of information here, and obviously stay tuned because we're going to have the post-election session scheduled on December 9th with Chris again. And thank you, Chris, for your participation as well. If you have any questions, I know that things come up and you may not have any questions now, but please feel free to reach out. You know, more than happy to assist you in the meantime. And then before we go, we do have a survey to complete for your feedback. Let us know how we did, help us to continue to improve, any other topics that you are interested in as well. We'll also be sending out the link of this recorded session so that you can revisit this topic, forward on to your peers and colleagues. And also just to let you know, we're continuing this educational series. We have Wednesday, November the 11th is our next one. It will be featuring leveraging healthcare technology. It's already up on the site, so you can begin registering. We also have the next session with Chris on December 9th as well. Really just want to thank you again for joining. Look forward to seeing you at one of our next sessions for our healthcare education series. Navigating healthcare trends and technology. So we do have a couple minutes left. Otherwise, you can sign off, and we look forward to seeing you again. Thanks so much.